Then the three expressions may be used to describe the hydrocephalus, and these are the manifestations of hydrocephalus in the plain X-ray of the skull. They appear in the form of widening of the sutures, increase in the craniofacial ratio, the discrepancy between the face and the skull, bulging of the fontanelles before fontanelle closure, erosion of the dorsum celli after closure of the fontanelles, and the old expression which is known as the silver bitin appearance, which describes the convolutional impressions on the calvareal bones. And actually we use nowadays CT and MRI for evaluation of the hydrocephalus, and to see the extent, the type, and the cause of the hydrocephalic changes. An important issue is to discriminate between hydrocephalus and atrophy, and in the MRI in the sagittal view there are some important findings which can help in this discrimination. These findings include enlargement of the anterior and posterior recesses of the third ventricle. You see the third ventricle is ballooned. Here are the anterior recesses, and here the posterior recess. Then downwind convexity of the floor of the third ventricle. The third ventricle, the floor is almost horizontal, and in this case you can see there is bulging or sagging of the floor of the third ventricle. And of course the dilatation of the temporal horns helps also to discriminate between atrophy and hydrocephalus. Then there are some measurements that can be done so that we can diagnose hydrocephalus in doubtful conditions. These measurements include the ventricular angle, and this is the angle between the frontal horns of the lateral ventricles. In normal cases, this angle is relatively more wide than in cases of hydrocephalus. It became more acute. Then effacement of the cortical sulci, and this is a very important issue in the discrimination between atrophy and hydrocephalus. In cases of the hydrocephalic changes, you cannot identify the cortical sulci because they are effaced. While in atrophy, you can see that the cortical sulci are also dilated. The ventricles are dilated and the cortical sulci are dilated. Then the periventricular edema means that the increased intraventricular pressure is reflected by retrograde extension of the CSF through the ventricular wall, what we call the periventricular edema. This hypodensity around the ventricles means that there is retrograde transependymal CSF permeation. Then in order to discriminate atrophy from hydrocephalus, these angles are of little help, but the most important issue, as I have said, is the state of the cortical sulci. In atrophy and hydrocephalus, the ventricles will be dilated, but in atrophy, the cortical sulci will also be dilated. And in cases of hydrocephalus, you will see effacement of the cortical sulci all around the cerebral cortex. Then we should have some idea about the CSF production and flow. The CSF, of course, is produced by the choroid plexus, which is present in all ventricles, in the lateral ventricles, in the third ventricle, and in the fourth ventricle. But the main brunt is directed to the choroid plexus in the lateral ventricle. And the CSF is excreted by the choroid plexus in the lateral ventricle. Then it goes from the lateral ventricles to the third ventricle via the foramina of Monro, then from the third to the fourth via the aqueduct of Sylvius, then from the fourth to the subarachnoid space around the brain through the outlet foramina of the fourth ventricle. The CSF is excreted at this rate, which is half a liter per day. Then after the circulation of the CSF reaching the subarachnoid space, it will be absorbed by the arachnoid villi and excreted in the dural sinuses. Then one of the causes of hydrocephalus is thrombosis of the dural sinuses. Then you block the drainage of the CSF. Patients with hydrocephalus usually complain of these issues such as lethargy, vomiting, headache, and signs of increased intracranial pressure. This is the flow of the CSF from the third ventricle from the lateral ventricle to the third via the foramina of Monro, from the third to the fourth via the aqueduct of Sylvius, from the fourth to the subarachnoid space through the outlet foramina of the fourth ventricle. Then we have to discriminate between two major types of hydrocephalus. We have what's called obstructive hydrocephalus and non-obstructive hydrocephalus. The non-obstructive hydrocephalus is caused by the presence of a tumor in the choroid plexus over-secreting the CSF. There is no obstruction, but there is overproduction of the CSF. Then the obstructive hydrocephalus is further subdivided into two major entities, what we call the communicating hydrocephalus and the non-communicating hydrocephalus. In cases of the communicating hydrocephalus, the obstruction will occur after the outlet foramina of the fourth ventricle. That is to say, the obstruction will be in the subarachnoid space, either in the arachnoid villi or in the venous sinuses where the CSF is drained. Then any obstruction at the level of the foramina of Monro, of the outlet foramina of the fourth ventricle and proximally will be considered as non-communicating hydrocephalus. But the communicating hydrocephalus, in obstructive communicating hydrocephalus, the obstruction will occur in the subarachnoid space and in the venous sinuses. Then obstructive hydrocephalus has many causes, and these causes differ according to the site of the lesion. Then we'll start first by the obstructive non-communicating hydrocephalus, and the first station is at the foramen of Monro. You know that the choroid plexus in the ventricle secretes the CSF, and the CSF leaves the ventricle through the foramen of Monro to the third ventricle. What happens if the foramen is obstructed? Then you will go to dilatation of the ventricle where the foramen is obstructed, and the other ventricle will be of normal shape. Then what are the causes of unilateral foraminal obstruction? Either congenital obstruction, congenital stenosis of the foramen of Monro, or due to kink of the foramen of Monro in cases of tumors causing shift of the midline structure to the opposite side. Then if you look to this example, this is MRI T1 and T2 weighted image. The right lateral ventricle is markedly dilated, the left lateral ventricle is almost normal, and this is a case of a female patient 18 months old of unilateral congenital foraminal stenosis on the right side. Then if there is a tumor on the left side compressing the left lateral ventricle with contralateral shift of the midline structure, you expect that the right lateral ventricle is dilated. Why? Because of the kink of the foramen of Monro of the right lateral ventricle. Then it will impede the CSF drainage from the ventricle, then the ventricle will be dilated. And this is another example of a glioma in the frontal lobe compressing the right lateral ventricle with shift of the midline structure to the left, and the left lateral ventricle is appreciably dilated due to kink of the foramen of Monro. Then what are the causes of bilateral foraminal of Monro obstruction? There are many lesions that can obstruct the foramina on both sides. One of the most important lesions is the colloid cyst, and the colloid cyst is a midline lesion which is centered to the foramina of Monro and the anterior part of the third ventricle. Then you got dilatation of both lateral ventricles, but the third is not dilated. Also an important lesion which is also well known, which is the tumor occurring in patients with tuberous sclerosis. Here you can see calcification in the wall of the ventricle, denoting the presence of tuberous sclerosis. Then a tumor which has a characteristic location and shape. The tumor is homogeneously enhanced and is located in the frontal horn of one of the lateral ventricles, and because of the size of the tumor, it encroaches on both foramina of Monro. Then you got bilateral foraminal obstruction and you got dilatation of both lateral ventricles. Actually, most of the suprasellar lesions like meningioma, glioma, and craniopharyngioma can extend high up to reach the anterior part of the third ventricle, then compress the foramina of Monro and cause bilateral dilatation of the lateral ventricles. Then we came to the second station, which is the station of the aqueduct between the third and the fourth ventricle. And the aqueductal stenosis is a well-known disease in the pediatric age group, where you can see dilatation of the third ventricle and dilatation of both lateral ventricles while the fourth ventricle is normal. Then congenital stenosis of the aqueduct is usually the commonest cause, but inflammatory conditions like encephalitis or cysticercosis and tumors occurring in the pineal body region, which is located here posterior to the third ventricle, or brainstem tumors can affect the aqueduct. And some of the books say that you can, in the sagittal image, see the region of the aqueduct, and you can see the congenital stenosis or the congenital web in the aqueduct, which is responsible for the supratentorial hydrocephalic changes. But actually in the CT and most of the MRIs, you can only see ballooning of the third ventricle, dilatation of both lateral ventricles, and the normal sized fourth ventricle. Then you can diagnose the possibility of aqueductal stenosis. And this is another case of aqueductal stenosis, where you can see the third ventricle is ballooned, both lateral ventricles are dilated, and the fourth ventricle is of normal size. MRI of a 17-month-old male with aqueductal stenosis, and you can see in the sagittal image the region of the stenotic area in the aqueduct, ballooning of the third ventricle and ballooning of the lateral ventricles with periventricular edema, which is due to retrograde transependymal CSF permeation. Then brainstem gliomas, which are also common in the pediatric age group, can compress the region of the aqueduct and also compress the fourth ventricle, producing a similar manifestation. This is a very important issue, which is known as late onset aqueductal stenosis. And you can see changes similar to aqueductal stenosis in children. You can see these changes in adult population. And if you see these manifestations, it's very important to do an MRI for this patient, looking for a very small tectal plate glioma or glioma of the tectal plate of the midbrain. And I have read this in the books, and during my practice I have been confronted with a case like this. Look at this patient who is a male, 29 years old, with dilatation of the third ventricle, dilatation of both lateral ventricles. The fourth ventricle is normal in what we call the late onset aqueductal stenosis. Then this is the case. Here you can see dilatation of both lateral ventricles, dilatation of the third ventricle, and if you look carefully to the region of the tectal plate of the midbrain, and you can see an abnormal signal, which is low in the T1 and high in the FLAIR, as well as high in the T2 weighted image, which has been proved to be a tectal plate glioma. Then whenever you see aqueductal stenosis in adult patients, you should investigate this possibility very carefully. Then what about the obstruction in the region of the fourth ventricle? You know that the CSF comes from the lateral ventricles to the third, then the aqueduct, then the fourth ventricle. Congenital atresia of the outlet foramina of the fourth ventricle is one of the causes of supratentorial and infratentorial hydrocephalic changes. Also, inflammatory lesions of the posterior fossa and tumors in the posterior fossa all can compress the fourth ventricle and produce hydrocephalus. And this is a case of atresia of the outlet foramina of the fourth ventricle. You see the fourth ventricle is ballooned, the third ventricle is also ballooned, and both lateral ventricles are markedly dilated. This is the difference between aqueductal stenosis and atresia of the outlet foramina of the fourth ventricle. In aqueductal stenosis, the fourth ventricle is normal, while in atresia of the outlet foramina, the fourth ventricle is ballooned. And this is the case of atresia of the outlet foramina of the fourth ventricle, where the fourth ventricle is ballooned, the third is ballooned, and both lateral ventricles are also ballooned. This is the male child, 3 months old, and the CT scan of his brain shows atresia of the outlet foramina of the fourth ventricle because the fourth ventricle is ballooned. Another case of atresia of the outlet foramina of the fourth ventricle with ballooned fourth ventricle. Then the tumors in the posterior fossa, like for example ependymoma in the fourth ventricle, or pilocytic astrocytoma, which is a cyst with an enhancing mural nodule compressing the fourth ventricle with supratentorial obstructive hydrocephalic changes. Also, medulloblastoma, a very famous tumor in the posterior fossa in the pediatric age group, can compress the posterior aspect of the fourth ventricle, resulting in supratentorial hydrocephalic changes, and you can see the periventricular edema due to retrograde transependymal CSF fibrillation. These were the causes of obstructive non-communicating hydrocephalus. Then we'll start the second issue, which is the obstructive communicating hydrocephalus. The causes of this hydrocephalus are usually located in the subarachnoid space, including the basal meningitis, subarachnoid hemorrhage, meningeal carcinomatosa, meningeal metastasis, and of course occlusion of the dural sinuses, which are the draining site for the CSF. And this is a simple case of subarachnoid hemorrhage, where you can see the blood is staining the cortical sulci and sylvian fissures, and some blood is also seen in the occipital horns of the lateral ventricles. The ventricles are dilated, the lateral ventricles, and the third ventricle as well. And this is the mechanism of communicating obstructive hydrocephalus, either in cases of dural sinus thrombosis or the presence of pulmonary hypertension impeding the venous drainage from the cranium, or skull base anomalies may result in venous hypertension with increased pressure inside the superior sagittal sinus. And this will result in decrease of the pressure gradient between the sinus and the arachnoid villi, and it will impede the drainage of the CSF, resulting in these dilated ventricles. Then there is a very important note here. The obstruction in the subarachnoid space will result in dilatation of the lateral ventricles, the third ventricle, and the fourth ventricle. Also, atresia of the outlet foramina of the fourth ventricle will result in dilatation of all ventricles. What is the difference? The difference is that the obstruction in the subarachnoid space will not affect totally all the arachnoid villi. Then there will be some arachnoid villi working for the drainage of the CSF. Then you will not see ballooning of the fourth ventricle. You will not see in obstructive communicating hydrocephalus, you will not see ballooning of the fourth ventricle, but in cases of atresia, you will see ballooning of the fourth and ballooning of the third as well. This is a case of basal meningitis due to TB. In the pre-contrast scan, CT scan, you can see abnormal high density in the sylvian fissures. After injection of contrast, you got marked enhancement of the leptomeninges and the basal cisterns with multiple tuberculomata scattered throughout the brain. Another case in a 15 days old male child with meningitis and you can see marked enhancement of the basal cisterns and Sylvian fissures, as well as the leptomeninges, with symmetrical dilatation of the ventricular system. In case of subarachnoid hemorrhage, and you can see dilated ventricles, and you can see sedimentation level in the occipital horns of the lateral ventricles. Then in this case, you can see dilatation of the lateral ventricles, ballooning of the third ventricle, but the fourth ventricle is not ballooned. What do we mean by ballooning of the fourth ventricle? A change in configuration. This is the normal configuration of the fourth ventricle. If it is maintained but dilated, then you think about communicating hydrocephalus, obstructive communicating hydrocephalus. But if you see the fourth ventricle is ballooned, then you think about atresia of the outlet foramen. This is another case of meningitis by MRI, and you can see enhancement of the leptomeninges and the dilatation of the ventricles. Then this is a very important issue that I also heard about in the books, but I have a case that I have seen in the clinical practice. This is what we call the trapped fourth ventricle. Patients with aqueductal stenosis, they put a shunt tube in the lateral ventricle to drain the lateral ventricle. Then for some reason, the outlet foramina of the fourth ventricle will be also obstructed. At that time, the lateral ventricles are drained, and the third ventricle are drained by the shunt tube. And the choroid plexus inside the fourth ventricle is still secreting CSF. Then the CSF cannot go up because of the aqueductal stenosis, and cannot go down because of the atresia of the outlet foramen. Then the fourth ventricle is trapped in the posterior fossa. And this can be clinically presented as a posterior fossa tumor, and it is nothing but just the dilatation, marked dilatation of the fourth ventricle because of the trapping. And here is my case. This is a patient, 20 months old, and shunted for supratentorial hydrocephalus due to aqueductal stenosis with development of a subdural hematoma. Lower down in the posterior fossa, you can see that the fourth ventricle is markedly dilated with periventricular edema due to retrograde transependymal CSF permeation, and the diagnosis here is trapped fourth ventricle because of the aqueductal stenosis and the occlusion of the outlet foramen. Then this is an issue of debate in the literature about the normal pressure hydrocephalus. You all know that hydrocephalus means increased pressure in the ventricles. And whenever the ventricles are dilated with normal pressure inside, you can diagnose atrophy. But this state of condition is in between atrophy and hydrocephalus. You remember that in hydrocephalus, the ventricles are dilated and the cortical sulci are effaced. In atrophy, the ventricles are dilated and the cortical sulci are dilated. In normal pressure hydrocephalus, the ventricles are dilated and the cortical sulci are normal. Then you look to this MRI and you can see that the ventricles are dilated, but the cortical sulci are within the normal range. The cause of this hydrocephalus is explained in the literature by this. They said that this patient may had before, in the early days of his life, a neonatal intraventricular hemorrhage, or a spontaneous subarachnoid hemorrhage, or got a traumatic insult or infection or surgery that has resulted in disturbance of the arachnoid villi, resulting in damage, permanent damage of the arachnoid villi, with this hydrocephalus manifesting late in life. This male patient, 71 years old, and you can see that the ventricles are dilated, the cortical sulci are normal, and is suspected to have a normal pressure hydrocephalus. This is the clinical triad of patients with normal pressure hydrocephalus, recent onset of gait ataxia or gait disturbance, dementia, and urinary incontinence. And in many of these cases, up to 50%, there is a history, remote history in early life of infection or hemorrhage. Then if you look to this MRI FLAIR image, you can see that the ventricles are dilated and the cortical sulci are normal. If the patient is clinically complaining of this, you may have the possibility of communicating normal pressure hydrocephalus. Then some of these patients will have a shunt tube to improve the symptoms. And these are the criteria that the patient will improve after application of the shunt, because many of these patients after application of the shunt may not improve at all, or may got some worsening of the symptoms. If these are the predictors for positive response to shunting, in the presence of gait disturbances, in the presence of upward bowing of the corpus callosum, which is seen in the MRI sagittal view, and you can see the bowing of the corpus callosum, the ballooning of the third ventricle, if there is a previous history of hemorrhage or infection which has affected the subarachnoid space, and the absence of cerebral atrophy or ischemia, these criteria will help the good results of the shunt tube. Then we came to the non-obstructive hydrocephalus, where the CSF is overproduced by a tumor of the choroid plexus. And this is a choroid plexus papilloma, which is centered to the region of the choroid plexus in the lateral ventricle, producing a lot of CSF. And this CSF may be produced 4 or 5 times the normal range. The normal range is half a liter per day, and you may got 2.5 liters per day CSF excreted by the choroid plexus, and cannot be adequately drained because of the limited capacity of the arachnoid villi. Another case of a non-obstructive hydrocephalus in the occipital horn of the lateral ventricle, in the lateral ventricles due to choroid plexus papilloma. Then a few words about the shunt complication, and these are 4 complications: either malfunction of the shunt tube, or shunt tube infection, or the production of subdural hematoma, or what we call the slit ventricle syndrome. Actually, to know the shunt tube malfunction, you need the follow-up scans. And if you see there is no change in the ventricular size, the periventricular edema is still present, you may suspect that the shunt tube is not working good. Then shunt tube may be infected through any abdominal condition, like peritonitis or abdominal trauma or surgery. Then the infection will ascend through the shunt tube to the ventricles. How to know that the ventricles are infected? Simply you see that enhancement of the ventricular wall and the ventricles are markedly dilated, then you may reach the diagnosis of a ventriculitis or ependymitis or ventricular infection. And the old shunt tubes, whenever they were applied, they may produce some subdural hematoma due to sudden decompression of the ventricle. And the new shunt tubes, this is not a complication with the new shunt tubes. Here you can see one of the old shunt tubes applied in the ventricles, which are totally collapsed with bilateral chronic subdural hematoma and meningeal calcification as well. Then this is a case of a shunt tube complicated by subdural hematoma on the right side by MRI T1 weighted image. Then you came to the slit ventricle syndrome. The slit ventricle syndrome means that the ventricles are markedly collapsed and the patient is complaining of symptoms of hydrocephalus. What happens in this syndrome? If you put a shunt tube in the ventricles and you drain the CSF perfectly, the patient will not complain. And upon follow-up studies, you get attenuated ventricles. Never write this is a slit ventricle syndrome. When you write in the report that this is a slit ventricle syndrome, one, the ventricles are collapsed and the patient is complaining. In cases of chronically drained shunt tube, the ventricles are collapsed and by time the ventricular wall is fibrosed. Then the shunt tube, due to any reason, will become blocked. And the choroid plexus will continue to secrete CSF, and the ventricles, because of fibrosis of its wall, cannot re-expand. Then there is marked increase in the pressure in the ventricle, which cannot expand. Then this is what we call the slit ventricle syndrome. The patient will complain of severe symptoms of hydrocephalus, in spite of the ventricles are markedly attenuated. Then at that time you can say this is a slit ventricle syndrome. Then we came to some special types of hydrocephalus, and I will give you some hint about these four types: the holoprosencephaly, the hydranencephaly, then the Walker anomaly, and the the Chiari malformation. We start by the holoprosencephaly, which is presented in the literature into three types: the A-lobar type, which is very common, the semi-lobar, and the lobar type, which are less common. Then the A-lobar type is just what we describe in the report, a monoventricle. Both cerebral hemispheres are fused, and the ventricular system is represented by a bag filled of water or CSF. There is no midline structures. There is no falx. There is no septum pellucidum. There is no corpus callosum. All the midline structures are absent. And this is an easy diagnosis, even intrauterine, through the either through the transcranial ultrasound after birth, or even in utero by the transabdominal ultrasound. Then if you see this characteristic configuration where the ventricles are represented by a single bag filled of water, then you know that this is the holoprosencephaly A-lobar type. No midline structures, no falx, no corpus callosum, no interhemispheric fissure, no third ventricle, and also no sylvian fissures. And you can see a bag of water filled representing the ventricular system. Most of the brain brain tissue in the supratentorial area is missing, except for some of the frontal brain tissue. Then this is a case of A-lobar type holoprosencephaly. The ventricles are fused into a single bag filled with CSF in the mid portion of the brain. Another case of A-lobar type holoprosencephaly showing the same configuration. Then you came to the semi-lobar type, which means that there are some development towards the normal configuration. And you can see some attempt to formation of the frontal horns and the occipital horns. But still, most of the midline structures are missing. The falx may be rudimentary. The interhemispheric fissure may be hypoplastic. At that time, you can diagnose this possibility of semi-lobar type holoprosencephaly. Whenever there is what seems like the frontal horns and the occipital horns, the septum pellucidum is missing, the falx is rudimentary, the interhemispheric fissure is incomplete, and the basal ganglia are fused, then you are dealing with the semi-lobar type holoprosencephaly, another case of semi-lobar type holoprosencephaly. Then you came to the second issue, which is hydranencephaly. And in this hydranencephaly, most of the brain tissue is missing, especially the frontal area, which is the opposite that is found in the holoprosencephaly. The salami are preserved, as you can see in this case, and very importantly, you can see the falx. This is very important in cases of hydranencephaly. While in holoprosencephaly, you cannot see the falx, and the brain tissue preserved is in the frontal area, while in the hydranencephaly, the brain tissue preserved is more or less in the temporal and the posterior areas of the brain. This is a classic presentation of hydranencephaly. The whole brain is represented by a bag filled with water. The falx cerebri is present. And this is another case also of hydranencephaly, and you can see the presence of the falx. Sometimes in cases of severe hydrocephalus, especially due to atresia of the outlet foramina or aqueductal stenosis, the ballooned lateral ventricles may appear like this. But in every case, you should find traces of brain tissue outside the dilated ventricles in cases of aqueductal stenosis or atresia of the outlet foramina. But in hydrocephaly, you do not see any brain tissue outside the CSF because there is actually no brain tissue. This is just a fibrous membrane filled with CSF. Then we came to the third issue, which is the Dandy-Walker malformation, which is included in a group known as posterior fossa cystic malformations. In this group, they present in a similar way, more or less a similar way, by a cyst in the posterior fossa. And this, according to the relation of the cyst to the fourth ventricle, if it is communicating or not, we can see these malformations. We start first by the Dandy-Walker malformation, where the posterior fossa cyst is communicating with the fourth ventricle through the absent vermis. Then in this condition, the vermis is aplastic and the cerebellum is hypoplastic because the cyst is occupying most of the posterior fossa cavity. Then the posterior fossa in Dandy-Walker is enlarged. And because of this anomaly, the supratentorial ventricles are dilated. And this is the case of Dandy-Walker. You see large posterior fossa cyst by MRI T1 weighted image communicating with the fourth ventricle through aplastic vermis. The cerebellum is hypoplastic and the lateral ventricles are dilated due to hydrocephalus. Another case of Dandy-Walker malformation, posterior fossa cyst communicating with the fourth ventricle through the aplastic vermis. The cerebellar hemispheres are hypoplastic, the supratentorial ventricles are dilated, and the patient also has a occipital meningocephaly. Then the Dandy-Walker malformation and many of the hydrocephalic changes may be associated with agenesis of the corpus callosum. And this is a case of Dandy-Walker malformation. You see a posterior fossa cystic lesion which is communicating with the fourth ventricle through aplastic cerebellar vermis, and you see a dilated lateral ventricles. And in the sagittal view, you cannot see the corpus callosum. Look to the normal case. This is the corpus callosum, and this is the cerebellum, this is the fourth ventricle, and the fourth ventricle is not communicating with the cisterna magna because the vermis is present. But here, the cisterna, the fourth ventricle is communicating with the posterior fossa cyst, denoting Dandy-Walker malformation. Then, in some cases, the vermis is not aplastic but hypoplastic. And there is a remnant tissue of the cerebellar vermis, and the cerebellar hemispheres are more or less within normal size, and you may got some dilatation of the supratentorial ventricles, what we call the Dandy-Walker variant. And if it is a Dandy-Walker original case, you will not find any of the vermis in this location. Then this is a normal variant, which is known as the mega cisterna magna. The mega cisterna magna is just an enlargement of the cisterna magna in the posterior aspect of the posterior fossa. In this case, you will find a normal vermis, a normal fourth ventricle, and a normal supratentorial ventricular system. And there is no hydrocephalus, there is no communication between the cyst and the fourth ventricle. Everything is okay. The only abnormality here is that the cisterna magna is huge, and this is known as the mega cisterna magna. Then behind the cerebellum, an arachnoid cyst may be present. In this case, the arachnoid cyst will compress the cerebellum. It will compress also the fourth ventricle, resulting in supratentorial hydrocephalic changes. But the vermis is okay, and the cerebellum is okay. This is the difference between the Dandy-Walker condition. And this is a case of arachnoid cyst in the posterior fossa, where you can see a posterior fossa cyst which is compressing the cerebellum and the fourth ventricle. The vermis Okay, no problem. Very good. Okay. The vermis is present and the cerebellum is also present, but you can see supratentorial hydrocephalic changes due to compression of the cerebellum and the fourth ventricle. Then here are the three different cases of posterior fossa cystic structures. In the Dandy-Walker anomaly, you can see the retrocerebellar cyst communicating with the fourth ventricle with supratentorial hydrocephalus. In the megacisterna magna, everything is okay about unless except for enlargement of the cisterna magna. And in the retrocerebellar arachnoid cyst, you can see the cyst not communicating with the fourth ventricle with supratentorial obstructive hydrocephalic changes due to compression of the fourth ventricle. Then we came to the last type, which is the Chiari malformation, and this malformation has been described by Hans Chiari in 1891. The Chiari-1 malformation is considered the normal variant, where all the Chiari malformations are in the form of a downward descent of some of the contents of the posterior fossa into the upper part of the cervical spinal canal. In Chiari-1, it is a simple anomaly, and only the cerebellar tonsils descend in the foramen magnum. You see, this is the edge of the foramen magnum, and this is the cerebellar tonsil, which has descended posterior to the cervical spinal cord. No compression of the fourth ventricle, no hydrocephalic changes, and this is a simple anomaly which may be considered as a normal variant. The Chiari-2 malformation, which represents about 40% of the causes of hydrocephalus in children, there are more structures descending into the upper part of the cervical spinal canal, including the cerebellar tonsils and the vermis and part of the medulla oblongata. Then the posterior fossa will be small size due to some of the contents are in the cervical spinal canal. These conditions are associated with lumbar meningeocele in all cases, in 100% of the cases. Then downward of the descent of the medulla and vermis, as well as the cerebellar tonsils, will be associated with compression of the fourth ventricle. Then the patient will got supratentorial hydrocephalus. Then there are manifestations of the Chiari at 3 levels: in the cervical region, in the posterior fossa, and in the supratentorial area. In the posterior fossa, you got a small sized posterior fossa because some of the contents are in the cervical spinal canal. Number 2, you got gapping of the edges of the foramen magnum to accommodate the descent of the cerebellar structures. Then you have also concave clivus, also for the same reason. And the fourth ventricle may be totally attenuated, you cannot see the fourth ventricle, or may be stretched and tube-like, and this can be seen in the sagittal images of MRI. This is the appearance of Chiari. In this case, you can see that the third ventricle is slightly dilated, the lateral ventricles are dilated, the fourth ventricle is not seen, is markedly attenuated. Then anyone may think about the aqueductal stenosis, where the fourth ventricle is attenuated and the third ventricle as well as the lateral ventricles are dilated. There are major differences between the Chiari and the aqueductal stenosis. Number 1, in the aqueductal stenosis, the third ventricle is ballooned because the obstruction is very near to the third ventricle, and this is not the case of the Chiari. In aqueductal stenosis, the lateral ventricles are symmetrically dilated. The frontal horns are dilated and the occipital horns are dilated. But in Chiari malformation, the occipital horns are markedly dilated compared to the frontal horns, and this is what is known as the colpocephaly, which describes that the occipital horns are markedly dilated compared to the frontal horns. Then this is another case of Chiari malformation, and the fourth ventricle is attenuated and not seen, The third ventricle is not ballooned. The lateral ventricles show the classic colpocephaly, with the frontal horns are much less dilated compared to the occipital horns. Then, in the upper part of the cervical spinal canal, you can see these changes. The cerebellum and the medulla behind the spinal cord. This is the cerebellum, and you can see part of the cerebellum is descending behind the cervical spinal cord. This cervicomedullary kink is not usually seen on imaging, but it occurs actually in the clinical practice because part of the medulla has to descend behind the cervical spinal cord. This will result in a peak or a kink at this place, and it cannot usually be seen by imaging. Then elongated tube-like fourth ventricle. This is the fourth ventricle. Instead of the normal configuration, it is elongated and tube-like. A spinal dystrophism in the form of lumbar meningocele in almost all cases of the Chiari malformation. The supratentorial structures include the well-known hydrocephalus with colpocephaly. You can see small frontal horns compared to the occipital horns. Number two, large basal ganglia, where indenting the lateral ventricles, forming what's known as the inverted 3. You can see this configuration because of the indentation of the caudate and the thalamus on the ventricular system, giving the configuration of inverted 3. Then beaking of the tectum. You remember that this is the quadrigeminal cistern and this is the tectum of the midbrain. Whenever the posterior fossa structures descend in the upper part of the cervical canal, the tectum will also descend, and you got beaking of the quadrigeminal cistern, which is beautifully seen, especially after shunting. Then one of the important manifestations of Chiari malformation is what is known as the fenestrated falx. What do we mean by fenestrated falx? And you can see in the midline, brain tissue crossing the midline, then coming back across the midline once more. If you see this appearance, this is classic for what is known as fenestrated falx, which is one of the manifestations that can be clearly seen in Chiari malformation. In this patient also you can identify what is known as beaking of the tectum. By CT, this is a case of Chiari malformation after shunting, and you can see attenuated ventricles, you can see beaking of the tectum, and you can easily identify what is known as the fenestrated falx. Then Chiari 3 malformation is more of the posterior fossa contents descend, but because of the absence of adequate place in the upper part of the cervical spinal canal for the descent of the cerebellar tissue in the upper part of the cervical canal, in these cases we should have an occipital meningocele or an upper cervical meningocele to accommodate for the posterior fossa structures descending into this particular area. And it is better to call this an occipital encephalocele rather than Chiari 3 malformation. Then in cases of hydrocephalus, you may get abnormalities in the corpus callosum, including hypogenesis and agenesis of the corpus callosum. This is the normal appearance of the corpus callosum, which is formed of 4 parts: the rostrum, the genu, the body, and the splenium. The splenium is the last to be formed, followed by the rostrum. Then in cases of agenesis of the corpus callosum or hypogenesis of the corpus callosum, it will start first by the rostrum, then the splenium, then the body, and then the genu of the corpus callosum. Then we came to the questions. What do you think about this case? A lobar holoprosencephaly. Okay. نعم. Aqueductal stenosis. Yes, very good. This is a trapped fourth ventricle. These are the lateral ventricles which are decompressed by the shunt tube with the resultant subdural hematoma, and the fourth ventricle is ballooned as seen in the sagittal and in the axial images. This is the trapped fourth ventricle with subdural hematoma. Hydranencephaly. Chiari-2 malformation. Yes, very good. Atresia or stenosis, congenital stenosis of the foramen of Monro of the right lateral ventricle, unilateral foraminal stenosis. This is not okay. Yes, then the Walker malformation, posterior fossa cyst communicating with the fourth ventricle through aplastic cerebellum. Communicating hydrocephalus, very good. Normal pressure hydrocephalus, you got dilated ventricles with normal cortical sulci. And here is the fourth ventricle is normal, the third ventricle is dilated, the lateral ventricles are dilated. Yes, and we are not sure except by MRI that we have tectal glioma, but here you diagnose late onset hydrocephalus and you recommend MRI to assess the possibility of tectal glioma. Yes, hypogenesis of the corpus callosum. There is a small part of the corpus callosum here, and you can see the classic configuration of the lateral ventricles. Intraventricular hemorrhage. Communicating hydrocephalus due to subarachnoid hemorrhage with intraventricular extension. Chiari-2 malformation with 3 other findings. Fenestration of the falx, very good. Peaking of the tectum, very good. Agenesis of the corpus callosum, very good. Okay. Bilateral chronic subdural hematoma complicating the shunt tube. Okay, Chiari-2 malformation with shunt.
So it's not associated with meningosis?
Sorry. Yes, type 2 should be associated with 100% in the lumbar meningitis. And this is one of the helpful signs. If you are confronted by a case and you think about this is aqueductal stenosis or Chiari, if the patient has a meningocele, you can go for Chiari. Okay. Unilateral foraminal stenosis. Then the Walker variant. There is a small part of the vermis which is located here, and there is a fatty structure showing high signal in the T1. This fat, which represents lipoma in the quadrigeminal system and the vermis. Okay. Tumor.
Blocking the foramen module on the right side.
Where is the tumor?
The falx is displayed.
Yes, the falx is displaced, but there is no tumor here. You can see enhancement of the basal cisterns and the cortical sulci, which is a case of meningitis. And the cause of the swelling of this hemisphere is the ischemic changes which are usually accompanying the meningitis due to stenosis and vascular thrombosis.
So what was it do?
and is also edema, ischemia and edema. These are the complications of meningitis, including hydrocephalus, sinus thrombosis, subdural and epidural emboyema, parenchymal infection and infarction, ventriculitis, and ependymitis. Yes, this is the holoprosencephaly, a lower type, and thank you very much.